Hello everyone, just wait. Please check my voice. Okay. Hello students, hello all of you. This is a FMGE IBQ series. IBQ series means image based question. So here we will discuss the frequently asked images or questions which are related with the images and that are frequently asked in the FMGE examination. Okay. So see, in this topic we'll discuss the some vitamins. For example, we'll discuss the important vitamin, that is niacin, and the disorder related with niacin, that is pellagra. We'll discuss the thymine pyrophosphate and beriberi. Then we'll discuss the electron transport chain and inhibitors of electron transport chain. Then we'll discuss the hyperlipoproteinemia or hypolipoproteinemia. Then minerals, some important minerals we'll discuss. Then apart from these important questions, so for example, niacin is frequently asked topic, thymine pyrophosphate is frequently asked topic. Then inhibitors and uncouplers of electron transport chain, some basic questions that are frequently asked. For example, glycosaminoglycans, they are frequently asked. Then the sphingolipids and disorders and disorder. For example, Gaucher's disease, the repeatedly asked question, Gaucher disease and that crumpled tissue paper or wrinkled paper appearance. This is important one. Then the amino acid ureas, for example, phenylketonuria, maple syrup urine disease, homocystinuria. These are the important questions. PKU, maple syrup urine disease, alkaptonuria, albinism. These are the important questions. So we'll discuss the some important images. For example, km and vmax. What happens to km and vmax in various type of inhibition, competitive, non-competitive and uncompetitive inhibition? What happens to km and vmax? So these are the repeatedly asked images, repeatedly asked question in the FMG examination. So prepare for the basic topic first and then go for the difficult topic, and prepare for the repeatedly asked question. Prepare for the PYQs, prepare for the PYTs, previous year topics. So that is important while when we prepare for the FMG examination. Now this is very famous image and very this is frequently asked image in the any entrance examination. Particularly this topic is very important in the NEET PG exam, in the FMG exam, also in the INI CET exam. This topic is very important. And this typical shape of, see here image, we will discuss the image first. Now see the necklace shaped dermatitis. It is necklace shaped dermatitis. Necklace shaped dermatitis. Okay. Now read the question. A 34-year-old male presented with diarrhea and lesion over his neck as shown in the image below. See the lesion as shown in the image below. Maize was a staple diet to him for prolonged period. The condition occurs due to deficiency of. Now this is a repeatedly asked question. This is PYQ, already a PYQ, because of deficiency of niacin. Classical 3Ds: diarrhea, dementia and dermatitis. All of you know that 3Ds: diarrhea, dementia and dermatitis. These are the features of niacin deficiency. Now this is Castle's necklace, erythematous rash on sun exposed part of the body, particularly involving the neck and hand and feet, giving the glove and stocking appearance of hand and feet. So this is erythematous, clear demarcation from the normal skin, erythematous rash on sun exposed part of the body because of niacin deficiency. Now why there is maize here? So see, when we eat maize or jawar as a staple diet, maize or jawar as staple diet. In the maize, the niacin, it is present in bound form, so it is unavailable for the absorption. And in jawar, there is leucine, there is high leucine content in the jawar, which inhibit the enzyme QPRTase, quinolinate phosphoribosyl transferase. This is enzyme which is required for conversion of tryptophan into NAD. So all of you know that 60 milligram of tryptophan will give 1 milligram of niacin. Niacin. So some requirement of niacin, it is fulfilled from the tryptophan. Here tryptophan is converted into niacin. And see, when we eat maize as a staple diet, when we eat jawar as a staple diet, it means it inhibits the conversion of tryptophan into niacin. So it is means it decreases the niacin synthesis, so that causes classical 3Ds of the pellagra: diarrhea, dementia and dermatitis. Okay, so remember this, niacin deficiency is there when we eat maize and jawar as a staple diet, when there is deficiency of vitamin C. It is when we take maize, jawar as a staple diet. Second, when there is B6, vitamin B6 deficiency, because it is required for the kynureninase activity, which is important in tryptophan to niacin conversion. Then Hartnupp's disease, there is defective absorption of tryptophan from the intestine. Hartnupp's disease, defective absorption of neutral amino acid and specifically the tryptophan. So decreased absorption of tryptophan, that causes the pellagra like symptoms. Also it causes the ataxia, means lack of coordination. So maize, B6 deficiency, Hartnupp's disease, then carcinoid syndrome. What is carcinoid syndrome? It is argentaphinoma. It is tumor of argentaphin cell of the intestine, where tryptophan is converted into serotonin. Serotonin. So tryptophan is not available for formation into NAD. So carcinoid syndrome, there is flushing, there is diarrhea like symptoms in the carcinoid syndrome. So maize, jawar eating population, then B6 deficiency, Hartnupp's disease, carcinoid syndrome and dietary deficiency of niacin, that causes the pellagra like symptoms, that is classical 3Ds. Now see this question here, zinc. So this is wrong here. So it's zinc also causes the dermatitis, but in zinc there is diarrhea, alopecia, dermatitis and delayed wound healing and loss of taste sensation. Also it affects the reproduction, zinc, because zinc is required for the formation of germinal epithelium. So see, iron deficiency causes pallor, decreased hemoglobin synthesis, means it causes the pallor, which is fatigue, weakness like symptoms are there in iron deficiency. And laboratory parameters, they are affected in the iron deficiency, particularly MCV, MCH, it is affected, and TIBC increases in the iron deficiency. Zinc deficiency, diarrhea, alopecia, dermatitis. Dermatitis involves the acral part of the body. It involves the finger, nose, toes, perineal area in the zinc deficiency. Also zinc deficiency causes delayed wound healing. It causes loss of taste sensation. Also it causes the uh, it affects the reproduction, because it is required for the germinal epithelium, maintenance of germinal epithelium. So DAD is for the zinc deficiency. Thiamine deficiency causes the beriberi, which particularly dry beriberi or wet beriberi. In the dry beriberi there is neuritis, neuropathy is there, paresthesia, numbness, loss of pain sensation. So calf muscle tenderness is there. So thiamine deficiency causes dry beriberi, that is peripheral neuropathy in dry beriberi, and wet beriberi, it is the high output cardiac failure. Remember, thiamine deficiency causes high output cardiac failure because of peripheral vasodilation, that causes dyspnea, pulmonary edema like symptoms, and the accumulation of fluid in the various pericardial pleural space. So thiamine deficiency causes the beriberi. Beriberi का literal meaning होता है weakness. And niacin deficiency causes 3Ds: diarrhea, dementia and dermatitis. So this is all about the niacin in short. Now see second. So this is important image and very easy image. So see, there is hyperkeratinized plaque triangular white opaque plaque on the conjunctiva. This is triangular white opaque plaque on the conjunctiva. It is known as Bitot spots. See, the following is due to deficiency of. Now here see, vitamin C deficiency causes scurvy. Vitamin K deficiency causes bleeding tendencies. Vitamin A deficiency causes vision impairment. Involvement of eye is there in the vitamin A deficiency. And vitamin E is the antioxidant, and deficiency of vitamin E causes axonal degeneration, and it affects the spinocerebellar tract. So there is lack of coordination, areflexia, also myopathy, retinopathy, neuropathy will be there in vitamin E deficiency, but it is very rare because it is present in all vegetable oils, vitamin E. Okay. Now see, so here answer is vitamin A deficiency, which causes vision impairment. So there is involvement of eye in the vitamin A deficiency. Second, there is phrinoderma, toad-like skin. Also toad-like skin is there in essential fatty acid deficiency. Now the first manifestation in vitamin A deficiency is the night blindness. Night blindness means increase in the dark adaptation time. Night blindness is the first feature. Nyctalopia is the first feature of vitamin A deficiency. Okay, then Bitot spot, conjunctival xerosis, then corneal xerosis, then keratomalacia, then blindness. So these are the features of vitamin A deficiency. And which form of vitamin A is important for the vision? It is retinal. It is retinal, which is present in rhodopsin. Rhodopsin is 11-cis retinal plus opsin. 11-cis retinal plus opsin. Okay. So vitamin C deficiency causes scurvy, bleeding tendency, bleeding gums, and the petechial hemorrhages all over the body. It causes the pseudo arthritis because of effusion in the joints. So vitamin K causes the bleeding tendencies, and vitamin E causes the axonal degeneration. So this is a case of vitamin A deficiency. This is Bitot spot. Now third case, see, a patient presented with reduced level of high density lipoprotein. So decrease HDL and ABCA1. There is this ABCA1, this transporter is affected. On examination, tonsils appeared as shown below. These are the tonsils. What is the diagnosis? See, yellow orange tonsil. It is pathognomic of Tangios disease. It is pathognomic of Tangios disease. Yellow orange tonsil. Peripheral neuropathy, yellow orange tonsil, and decreased HDL level. It is a diagnostic. These are the diagnostic features of Tangios disease. This is familial alpha lipoprotein deficiency. Alpha lipoprotein is HDL. Alpha lipoprotein deficiency means there is low level of HDL lipoprotein, and this ABCA1, these transporters ABCA1 and ABCG1, ATP binding cassette transporter A1 and G1, also scavenger receptor B1, these are involved in the transport of cholesterol. They are involved in the transport of cholesterol from tissue to the HDL. So discoidal, nascent discoidal HDL, it is converted into spherical HDL by the action of this transporter ABCA1, ABCG1 and scavenger receptor B1. These are responsible for transport of cholesterol to the HDL. So nascent discoidal HDL is converted into spherical HDL. So in this disease, there is defect in the transporter, that is ABCA1, that causes the Tangios disease. So there is decrease or low level, very low levels of the HDL. There is peripheral neuropathy in the Tangios disease, and this is the feature, the yellow orange colored tonsil. Orange colored tonsil, this is the feature of Tangios disease. Another alpha lipoprotein deficiency. There is alpha lipoprotein or HDL deficiency in the Norham's disease and the Fisheye disease. Here a beta lipoproteinemia, there is complete absence of beta lipoprotein. There is decrease in the beta lipoprotein. So VLDL, LDL and the VLDL and LDL and chylomicron will not form in the A beta lipoproteinemia. Hyperlipoproteinemia, there may be a history of xanthomas. There may be a history of xanthomas and elevated levels of TG, elevated levels of LDL, elevated levels of cholesterol will be there. Wolman's disease, the classical feature is adrenal calcification. In Wolman's disease, there is adrenal calcification. So these are the features of Tanger's disease, important one. Now this two topics here, they are in this question, two topics are important. First, ABC transporters, all ABC transporters, they are important. And second, hyper and hypolipoproteinemias, hyperlipidemias, they are important, particularly type 1, type 2A and the Tanger's disease. These three diseases are very, very important. Type 1, that is familial chylomicronemia, then type 2A, that is familial hypercholesterolemia, and the Tanger's disease, which is alpha lipoprotein deficiency. These three diseases are very, very important from the Fredrickson classification. See, these are the properties of the lipoprotein. In this property, what is, remember, just remember the protein content, lipid content, you will automatically see, if you remember the protein content, then this will be automatically, you can remember this lipid content. So protein content, it is increasing from chylomicron to the HDL. So HDL having the maximum protein content. Then the apoprotein, the important apoproteins, so B48, it is in the chylomicron, B100 in the VLDL, IDL and LDL, and ApoA, it is important in the high density lipoprotein. Now the functions, chylomicron, it is produced in the intestinal cell. It is produced by the intestine. So it is important for the transport of triacyl glycerol from intestine to the peripheral tissues. It is produced in the intestine. What is role of chylomicron? Chylomicron का role क्या है? Chylomicron, it transports the triacyl glycerol from intestine to the peripheral tissues. It is produced in the intestine by the RNA editing. Same gene will produce the B100, same gene will produce the B48. This is example of RNA editing. This is premature termination of protein synthesis. So CAA in the liver, which is in the intestine, is converted into UAA, lead to the 48% of the protein synthesis that causes the B48 synthesis in the intestine. So it is RNA editing example, B100 and B48. This is example of RNA editing. Now what is function of chylomicron? It is for the transport of exogenous triacyl glycerol. Exogenous means dietary, from intestine to the peripheral tissues. VLDL, it is for the transport of triacyl glycerol from liver to the peripheral tissues. From liver to the peripheral tissues. LDL, from liver to the peripheral tissues. That's why it is important. For it causes the deposition of cholesterol in the peripheral tissues, and it can cause atherosclerosis. When free radical causes the oxidation of LDL, it causes the atherosclerosis when it is present in excess. So that's why it is known as bad cholesterol. This is known as bad cholesterol because it is responsible for atherosclerosis when free radical damages, when there is excess of LDL is there, and free radical production or excessive stress that causes the oxidized LDL formation, that causes the formation of atherosclerosis via the LDL. That's why it is known as bad cholesterol. And this is good cholesterol because it is reverse transport of cholesterol from peripheral tissues to the liver, and it is important for metabolism of cholesterol by the liver. So this is HDL, high density lipoprotein. Now see, of these all, the two, the means यहाँ पे दो याद रखो आप. First, that is familial chylomicronemia, means there is increase in the chylomicron level. See, there is increase in the chylomicron level, and chylomicron carries the triacyl glycerol. That's why there is increase in the triacyl glycerol level. So patient serum will be lipemic serum. TG level, it is in the 1000, 1000, 2000, 3000, or it is higher level, 1200, 1300, or 2400, like that. So TG level, very high TG level, and because of increase in the chylomicron level, the serum of the patient that looks lipemic, that looks milky, that looks lipemic. This is a feature of familial chylomicronemia type 1. This is Fredrickson classification. And the familial chylomicronemia, it is due to lipoprotein lipase deficiency or ApoC2 defect. So this is important MCQ, lipoprotein lipase deficiency or ApoC2 defect. And second one, and in this disorder there is increased TG level, so there is a chance of pancreatitis in this type 1. There is chance of pancreatitis in the type 1 disease. And there is eruptive xanthomas, while in the type 2 there is tendon xanthomas. Tendons, they are involved in the type 2. So see, familial hypercholesterolemia, it is because of LDL receptor defect or ApoB100 defect. There is increased LDL level, increased cholesterol level, and there is tendon xanthomas. And as there is no increase in the TG, so there is no risk of pancreatitis, but there is increased risk of atherosclerosis because of increase in the cholesterol level. So these two, remember these two. First one is the familial hyperchylomicronemia, second one is the familial hypercholesterolemia. So ये दो याद रखो. Then the Tanger's disease, it is due to mutation in the gene ABCA1 transport protein which is required for transfer of cholesterol from cells to the HDL. So there is low level of HDL, enlarged yellow-orange tonsil, hepatosplenomegaly, and peripheral neuropathy is there. Fish-eye disease, there is partial LCAT deficiency, and Norum's disease. One more is there, Norum's disease. It is complete deficiency of LCAT. What is role of LCAT? Lecithin cholesterol acyl transferase. It is important for the esterification of cholesterol. Esterification of cholesterol, and cholesterol is converted into cholesterol ester. Now this lipid, this moves to the interior of HDL, which causes spherical HDL formation. So LCAT is important. Partial deficiency causes fish-eye disease. Complete deficiency causes the Norum's disease. So this is important in the hyperlipoproteinemia. See, when there is increased cholesterol level, there is tendon xanthomas. There is this is a type 2A hyperlipoproteinemia. There is risk of coronary artery disease. There is risk of atherosclerosis. In the when there is increase in the cholesterol level. When there is increase in the TG level, triglyceride, it causes eruptive xanthomas. TG levels, they are raised in type 1, type 4 and type 5. When there is increase in the chylomicron, it gives the milky appearance to the plasma or lipemic plasma or whitish plasma. This is found in the type 1, that is familial hyperchylomicronemia. So this is very, very important topic. Characteristics of lipoprotein, hyperlipoproteinemia, hypolipoproteinemia, functions of the lipoprotein, and the composition means protein content, lipid content, which is major apolipoprotein in that lipoprotein is important. So these all points are important in this. This is again very, very important and favorite question of the examiner. Look this question. See, this is also image. This is same image. See, and this image. Okay, so 3 questions are there. Just wait. So read this question. Hi Sommeraj. Damshalin. Hi Manoj Singh. Sahil. So what is the answer to this question? This is repeatedly asked question in the any entrance examination. Sphingolipidosis, very, very important question. Sphingolipidosis, repeatedly asked. Any exam, INICT, FMGE, and the NEET PG examination, repeatedly asked question. This is crumpled tissue paper appearance, wrinkled paper appearance of the macrophages. Wrinkled tissue paper appearance of the macrophages. So it is lysosomal storage disorder. See, a patient came with complaint of weakness and bony pain. On evaluation, anemia and hepatosplenomegaly was detected. Below is the histological picture showing cells in bone marrow. Which of the following enzyme is deficient? Which of the following enzyme is deficient? Wrinkled paper, tissue paper appearance, or crumpled paper appearance? Crumpled tissue paper appearance, it is a characteristic of which disease? Gaucher's disease. It is characteristics of Gaucher's disease. Yes, correct. Your drug of choice C. Correct. Hi Rishikesh. Hi Somyaraj. CML. See, Gaucher's disease, frequently asked question, Gaucher's disease. Each and every point about the Gaucher's disease, they are important. There is no cherry red spot in KGF. Remember that KGF means Krabbe's, Gaucher's and Fabry's disease. There is no cherry red spot. So mental retardation is very rare in the Gaucher's disease. Then there is intracytoplasmic inclusion bodies, lysosomal inclusion bodies, lysosomal storage disorder. There is accumulation of compound glucocerebrosides. There is absence of enzyme glucocerebrosidase. There is absence of enzyme glucocerebrosidase, that is beta glucosidase. Glucocerebrosidase. Accumulated compound is glucosyl ceramide. Glucosyl ceramide. Ceramide means fatty acid plus sphingosine. When glucose is added, it is glucocerebroside. It is glycolipid. It is glycolipid. In this, the sphingosine is the alcohol, amino alcohol. Okay. Now there is no cherry red spot. There is involvement of liver. There is involvement of spleen. There is involvement of bone marrow. So it causes pancytopenia, means decrease in cell count, all cell count. So decrease RBC, WBC, platelets, they are platelets. So anemia, thrombocytopenia, leukopenia means it is refractory anemia. Also there is avascular necrosis of the bone, frequent bone fracture, and there is X-ray deformity that is seen in the X-ray, that is known as Erlenmeyer flask deformity. This like end of the femur, this is like Erlenmeyer flask deformity is there on the X-ray. So this is very very important. Gaucher's disease, remember this point. So here answer is glucocerebrosidase. Answer is glucocerebrosidase. See this. A baby is being evaluated for delayed developmental milestones. On examination, the child has hepatosplenomegaly. Microscopic image of bone marrow evaluation is shown below. What is diagnosis? So it is Gaucher's disease, Niemann-Pick disease, Hunter disease, Hurler. Hunter and Hurler, these are the mucopolysaccharidosis. Niemann-Pick disease, this is Sphingolipidosis due to sphingomyelinase defect. In the Niemann-Pick disease, there is cherry red spot on the macula. In Hunter and Hurler, there is skeletal deformity, there is mental retardation. Along with that, skin lesions are there. Then in Hurler, there is cloudy cornea. So multi-system involvement, hepatosplenomegaly and multi-system involvement is there in Hunter and Hurler syndrome. While Gaucher's disease, see the crumpled tissue paper appearance, wrinkled paper appearance of the macrophages is the important clinical finding. So see, this is Erlenmeyer flask deformity. Erlenmeyer flask deformity on the X-ray. So there is a vascular necrosis of the bone. So it is glucocerebrosidase which is deficient here. Glucocerebrosidase. 21-year-old man with history of sudden rectal hemorrhage because of thrombocytopenia, decreased platelet count, easy bruising and easy there are bleeding tendencies in this patient, was referred to the GMC. On examination, hepatosplenomegaly was noted. Liver biopsy demonstrated tissue paper macrophages. So it is tissue paper macrophages. Investigation revealed anemia, leukopenia and the thrombocytopenia. X-ray showed Erlenmeyer flask deformity and eye examination shows no cherry red spot. So there is no cherry red spot in the KGF, that is Krabbe's, Gaucher and the Fabry's disease. So sphingomyelinase deficient in Niemann-Pick, hexosaminidase A in the Tay-Sachs disease, galactocerebrosidase in the Krabbe's disease and glucocerebrosidase in the Gaucher's disease. So this is each and every point in this disease is very very important. The following fundoscopy depict a characteristic finding. This finding is present in all of the following disease except, so there is no cherry red spot in the Gaucher's disease. There is no cherry red spot in the KGF, Krabbe's disease, Gaucher's disease, and Fabry's disease. Krabbe's disease, Gaucher's disease, and Fabry's. In these three disorder, there is no cherry red spot. While there is cherry red spot in Niemann-Pick disease due to sphingomyelinase defect, Tay-Sachs disease, this is due to hexosaminidase A, and there is no organ involvement in the Tay-Sachs disease. While Sendorf disease, it is same feature as that of Tay-Sachs disease, except there is involvement of organs. So heart is involved, hepatosplenomegaly is there in the Sendorf disease. These are the two GM2 gangliosidosis. GM2, there is accumulation of GM2 gangliosides in this Tay-Sachs and Sandorf disease. So this topic is very, very important. These are the deficient enzyme, and these are the substance which are accumulated in this disorder. Gaucher's disease, beta glucosidase or glucocerebrosidase. So glucosyl ceramide or glucocerebroside, they are accumulated. Remember, ceramide means sphingosine plus fatty acid. When glucose is attached, it is glucosyl ceramide or glucocerebroside. When galactose is attached, it is galactocerebroside or galactosyl ceramide. And galactocerebroside, it is important in the brain. It is important in the brain. So Gaucher's disease, beta glucosidase, this is important. Niemann-Pick disease, there is sphingomyelinase, there is cherry red spot on the macula in the Niemann-Pick disease, there is hepatosplenomegaly, and the red spot, cherry red spot on the macula. These are the features of Niemann-Pick disease. Krabbe's disease, this is due to beta galactosidase defect. Fabry's disease, this is alpha galactosidase defect. In Fabry's disease, there is telangiectatic skin lesion, that is angiokeratomas are there in the Fabry's disease. Then Tay-Sachs disease, it is due to hexosaminidase A defect, and in the Tay-Sachs disease, no organ involved, no organomegaly. Organs are not involved in the Tay-Sachs disease, while in the Sandorf's disease, there is involvement of organs. Hepatosplenomegaly is there, cardiomegaly is there. It is because of hexosaminidase A and B defect, and these both means Tay-Sachs and Sandorf, these are GM2 gangliosidosis. There is accumulation of GM2 gangliosides. Okay, so these are the important disorders in the sphingolipidosis, lipidosis, or the glycolipids. Now, which vitamin deficiency lead to following symptoms? So this is circumoral involvement. For example, cheilosis, glossitis, red colored tongue, angular stomatitis, then seborrheic dermatitis, and circumcorneal means the vascularization means pink eye. So conjunctivitis. So conjunctivitis, cheilosis, glossitis, these are the features, these are the deficiency manifestations of riboflavinosis. So these are due to deficiency of riboflavin B2. These are also feature of niacin deficiency in the early stages, but these are not characteristics feature of B3 deficiency. These are the characteristic features of B2 deficiency. कौन से feature बोला मैंने? Cheilosis, angular stomatitis, tongue involvement, then glossitis, circumcorneal vascularization, that is pink eye or conjunctivitis, and seborrheic dermatitis. These are the features of riboflavin deficiency. Niacin deficiency, diarrhea, dementia, dermatitis, vision involvement in the vitamin A deficiency, bitter spot, night blindness, and the keratomalacia will be there. Vitamin C deficiency causes scurvy. In the given diagram, identify drug Z marked by the arrow. So this is drug Z marked by the arrow. So now this is acting on vitamin K reductase. So it is vitamin K epoxide reductase. This is vitamin K epoxide reductase. See, so what is the answer here? Hi Apurva, hi Rishikesh, hi legendary Ritvik, hi Apurva, hi Soumya. Correct. Dicumarol is the answer. 54 divine. Hello. See, dicumarol and warfarin, they inhibit these are the oral anticoagulant, dicumarol and warfarin. Warfarin. So these are the oral anticoagulant drug that inhibits the vitamin K epoxide reductase enzyme, and these are the competitive inhibitors. These are the competitive inhibitors. Now see, vitamin K is among the ADEK. It is least important for the theoretical examination, but for the objective type examination, for MCQ based examination, vitamin K is very important because it is connecting link between the vitamin topic and the genetic topic. This is also question from the genetic topic because it causes the activation of factor 2, 7, 9, 10. Vitamin K causes activation of factor 2, 7, 9, 10 by post translational modification, post translational gamma carboxylation. Remember this, post translational gamma carboxylation. It is a function of vitamin K. So it converts inactive factor 2, 7, 9, 10 into active factors by the carboxylation, gamma carboxylation, gamma carbon by addition of COO negative charge, by addition of COO negative charge to the gamma carbon. This is gamma carbon of glutamate. Post translational gamma carboxylation imparts additional negative charge to the clotting factor, and it reacts with the calcium, the clotting factor 4. Calcium is the clotting factor 4 to form a complex which activates the various factors and that causes the clotting mechanism. So it is important in the clotting process. So activation of 2, 7, 19 by post translational gamma carboxylation. So vitamin K causes gamma carboxylation, biotin causes carboxylation. Biotin causes carboxylation, pyridoxal phosphate causes decarboxylation, and the thymine pyrophosphate causes oxidative decarboxylation. अभी क्या क्या बोला मैंने? See, gamma carboxylation, फिर बोला मैंने decarboxylation, removal of CO2, decarboxylation, फिर बोला मैंने कार्बोक्सिलेशन, उसके बाद बोला ऑक्सीडेटिव डिकार्बोक्सिलेशन. These are the important topics. Important. Now see here, for gamma carboxylation, it is vitamin K which is important. Vitamin K causes gamma carboxylation. This is post-translational modification in which glutamate is the acid. उसको already carboxyl group रहता है. The additional carboxyl group, gamma carbon पे additional carboxyl group, it is added by the vitamin K dependent carboxylation reaction. So gamma carboxylation of clotting factor 2, 7, 9, 10. This is vitamin K dependent reaction. Now decarboxylation reaction, it requires pyridoxal phosphate and it is important coenzyme for synthesis of neurotransmitters. So it is important for neurotransmitter synthesis. So glutamate is converted into GABA, then the DOPA is converted into dopamine. So neurotransmitter synthesis decarboxylation reaction is very important. Apart from the transamination reaction, PLP is required for the decarboxylation reaction. For the carboxylation reaction, biotin is required. Some are exception here that they are included in the biotin independent carboxylation reaction, which includes biotin independent carboxylation बता रहा मैं. So biotin independent carboxylation reaction, it includes the CPS1, CPS2 means urea cycle pyrimidine nucleotide synthesis, that is CPS1, CPS2 carbamyl phosphate synthetase 1, carbamyl phosphate synthetase 2. Then AIR carboxylase in the purine nucleotide synthesis, then gamma carboxylation and the malic enzyme. These are the biotin independent carboxylation reaction. यहाँ पे biotin नहीं लगेगा. But the important reactions where biotin is required, that is acetyl coenzyme A carboxylase in the fatty acid synthesis, propionyl coenzyme A carboxylase in the gluconeogenesis, uh, uh, and the pyruvate carboxylase in the gluconeogenesis. They are biotin dependent carboxylation reaction. And oxidative decarboxylation reaction, thymine pyrophosphate is required, that is pyruvate dehydrogenase complex, alpha ketoglutarate dehydrogenase complex. So remember this. For hydroxylation, vitamin C is required. Hydroxylation reaction, vitamin C is required. Okay, so these are the important reactions which require multiple coenzymes. Now see, these are the graphs which are very important. These are known as Line-Weaver-Burke plot. So it is Line-Weaver-Burke double reciprocal plot. So only point to remember in this graph that the X-shaped graph is there in case of competitive inhibition. In competitive inhibition, Km value increases and Vmax remain unaltered. Now remember one trick here, Vmax, maximum velocity, it either decreases or it remains constant. There is nothing like increase in the Vmax. If there is option increase in the Vmax, so just rule out this option first, increase in the Vmax. There is nothing like increase in the Vmax in the inhibition. Maximum velocity either remains same or it decreases. Okay, now in the competitive inhibition, Km increases and Vmax remain same, and there is X-shaped graph in the competitive inhibition, X-shaped graph. Okay, and there is increase in the Vmax. Why there is increase in the Km value? Because in presence of inhibitor, higher substrate concentration is needed to achieve the Vmax. So that's why there is increase in the Km value in the competitive inhibition. So simple type of graph, if you draw the simple type of graph, this is the curve and this is inhibitor. Second is the inhibitor. So higher substrate concentration is needed to achieve the Vmax. That's why Km increases and Vmax remains same in the competitive inhibition. So various examples are there. So methotrexate, then the lovastatin, then malonate, allopurinol. These are the different drugs which act through the competitive inhibition. In non-competitive inhibition, there is V-shaped graph. In the non-competitive inhibition, this graph is V-shaped. And in non-competitive inhibition, Vmax get lowered, Vmax decreases and Km remains same. So Km remains same and Vmax get lowered. Vmax get lowered in the non-competitive inhibition. So V-shaped graph. If there is question, if there is diagram, so if it is V-shaped, go with the non-competitive inhibition. Uncompetitive inhibition, this Line-Weaver-Burke plot is there is parallel lines, both decreases, Km decreases, Vmax decreases. So you may get question on Km and Vmax and these diagrams, Km, Vmax and this diagram. So competitive X-shaped graph, non-competitive V-shaped graph, and the uncompetitive inhibition parallel graph. In uncompetitive inhibition, both decreases. Remember that Vmax never increase. There is nothing like increase in the Vmax in presence of inhibitor. Competitive inhibition, Km increases because higher substrate concentration is needed to achieve the Vmax. In case of non-competitive inhibition, Vmax decreases because non-competitive inhibition, they in the non-competitive inhibition, it is some most of the time it is irreversible type of inhibition, a non-competitive inhibition. And in the non-competitive inhibition, Vmax decreases and Km remain same. So remember these three things and three diagrams in case of competitive, non-competitive and uncompetitive inhibition. And remember their examples. All of you know that the allopurinol act by two mechanisms. One is competitive and one is the that is mechanism based inactivation. Other word, it is suicide inhibition. Allopurinol is converted into alloxanthin, and it inhibits the xanthin oxidase enzyme, which is the enzyme of purine degradation pathway where uric acid synthesis occurs. So it decreases the uric acid formation. So that's why it decreases the symptoms of gout. It decreases the symptoms of gout. That's why allopurinol is given in the treatment of gout. Now see, here this question is taken for these two images. This is Benedict test, this is Rothra's test, deep purple ring. See this deep purple ring, this is Rothra's test. Benedict test. When Benedict test will be positive, when there is urine, when the blood level crosses the renal threshold, that is 180. Renal threshold is 180 milligram per deciliter. When it crosses the renal threshold, it appears in the urine. So when glucose appears in the urine, it gives the positive Benedict test. When there are ketone bodies, increased level of ketone bodies, it increases. There is very low threshold for the ketone bodies. If it goes above that, it crosses the it appears in the urine and it is detected by the Rothra's test. So Benedict test, Rothra's test. So change in color from green, yellow, orange, red and brick red. So color changes in the Benedict test because of reducing property, and the property in hot alkaline medium, there is formation of NADOL, which is the strong reducing agent which reduces the cupric ions into the cuprous ions. So there is formation of various colors. So that indicates the approximate amount of sugar present in the urine sample. While the Rothra's test indicate the presence of the ketone bodies, specifically acetone and the acetoacetate, but it is the beta hydroxybutyrate, it is not detected by the Rothra's test. For that, modified Rothra's test is needed for detection of beta hydroxybutyrate. Being the most common ketone body, beta hydroxybutyrate, it is not detected by the normal Rothra's test. Okay. It is a false ketone body. It does not have the keto group. It is having the hydroxyl group, but it is synthesized from the synthesized in the ketone body synthesis pathway. So it is included in the ketone body. So it is beta hydroxybutyric acid, which do not give the Rothra's test positive. Now see, 17-year-old boy diagnosed with diabetes, means insulin dependent diabetes mellitus, means age, according to the age, was brought to the hospital in semi-conscious and abnormal deep rapid breathing. Semi-conscious state and abnormal deep rapid breathing. This is known as Kussmaul breathing. This is very, very important clinical case, Kussmaul breathing, because this includes the carbohydrate metabolism, this includes the lipid metabolism, this includes the practical examination, this includes the acid-base imbalance. So four systems, four important topics they are involved here in this case. That's why this is important case for the entrance examination. Diabetic ketoacidosis. This is a case of diabetic ketoacidosis. So it also involves the acid-base imbalance. Means see now. So abnormal deep rapid breathing. His plasma glucose was 673 milligram per deciliter. Urine shows positive Benedict and Rothra's test, means reducing sugar is positive. Rothra's test positive means ketone bodies are positive. So ketone bodies are positive in the either in the starvation case or in the uncontrolled diabetes mellitus. But if it is Benedict test positive, means it is not a starvation case. It is a case of diabetic ketoacidosis. If both are positive, Benedict test, Rothra's test, both are positive, it indicates the diabetic ketoacidosis. Because in starvation only Rothra's will be positive, Benedict test will be negative. The blood investigation reveals following result: blood pH 7.21. Anything less than 7.35 is acidosis. So this is acidosis. Partial pressure of CO2 is 30 mmHg. 35 to 45 is the normal range. So there is decrease in the partial pressure of CO2, and the bicarbonate level 16 milligram millimole per liter. Already, actually in diabetic ketoacidosis, it goes below 14 millimole per liter, and that is a diagnostic criteria for diabetic ketoacidosis. Means yes, decay below 14 millimole per liter. Okay. Now see, so it is normal range is 22 to 28. So it is decrease, means it is metabolic acidosis. So it is metabolic acidosis, and this is compensation. This is compensation. Now how to diagnose acid base disorder? How to diagnose acid base disorder? See, so here answer is metabolic acidosis with compensation. With compensation, this is compensated. So with compensation, see, 7.35 to 7.45. If it is decreases, it is acidosis. Simple, this is acidosis. Label that patient as acidosis, label that patient as alkalosis if it is above 7.45. Okay, and this is primary defect. This is primary defect. If it is below 7.35, it is acidosis. If it is below, if above 7.45, it is alkalosis. So this is the first parameter. Second parameter, bicarbonate level. Now see bicarbonate 22 to 28 millimole per liter. If it is below this, this is alkali. Bicarbonate HCO3 is the alkali. If alkali decreases means acidosis. This is metabolic acidosis. Acidosis. This is metabolic alkalosis. If increase, metabolic alkalosis. Bicarbonate level, this is alkali reserve 20 times more than the acid, carbonic acid. So 22 to 28 millimole per liter bicarbonate level. If decreases, metabolic acidosis. If increases, metabolic alkalosis. Then PCO2. See, PCO2, partial pressure of carbon dioxide, 35 to 45 mmHg is the normal range. If acid, partial pressure of CO2 means carbonic acid. If acid increases, it is respiratory acidosis. If acid decreases, it is respiratory alkalosis. Alkalosis. Got it? This is primary defect. Now see, the parameter who goes with the pH is the primary defect. इसके साथ जो भी जाएगा वो primary defect. The parameter who goes with the pH is the primary defect. Other one is the compensatory mechanism. So see, if there is decrease in the pH and decrease in the bicarbonate level, it is metabolic acidosis. If there is increase in the pH and increase in the bicarbonate level, it is metabolic alkalosis. If there is decrease in the pH and increase in the PCO2, it is PCO2 means carbonic acid. Acid increase हो गया मतलब acidosis. So it is respiratory acidosis. And other parameter is the compensation. Parameter who goes with the pH is the primary defect. Other one is the compensatory mechanism. For example, in this case, see in this case, this is metabolic acidosis. This is compensatory mechanism, Kussmaul breathing, deep rapid respiration, hyperventilation to blow out the CO2. So CO2 will be washed out by this process. So it try to maintain the bicarbonate and carbonic acid ratio to 20:1. And this is Kussmaul breathing, hyperventilation. This is compensatory mechanism to blow out the CO2. That's why PCO2 level decreases. This is compensatory mechanism. So this is compensation. This is how we can diagnose the acid base disorder. Okay. Hi Ritvik. One important finding again with this, in the treatment we give the insulin, but when we give the insulin we also monitor the potassium level, because here there is in this patient there is increase in the potassium level. Hyperkalemia is there in the diabetic ketoacidosis. This is because of the redistribution of potassium ion in exchange of the hydrogen ion. To decrease the hydrogen ion concentration in the extracellular fluid, hydrogen moves inside the cell in exchange with the potassium. Potassium moves out. So there is hyperkalemia. But when we give the insulin in the treatment of diabetic ketoacidosis, patient को hyperkalemia है, we are giving the insulin to the patient, hyperkalemia है, and patient suddenly goes into hypokalemia when we give insulin because of rapid opening of the intracellular potassium channel which drags potassium inside the cell. Insulin dependent potassium channels, they open and drags the potassium inside the cells, and death of the patient can occur because of cardiac arrhythmias, cardiac arrest, because of hypokalemia. पेशेंट को हाइपरकैलेमिया था, हमने इंसुलिन दिया तो वो मरा कैसे? हाइपोकैलेमिया से. सो द स्ट्रिक्ट मॉनिटरिंग ऑफ पोटेशियम इज नीडेड हियर when we give the insulin therapy in the diabetic ketoacidosis. So this is again important question. This is fluoride bulb. This is sodium fluoride potassium oxalate. Fluoride bulb, gray cap tube, gray tube. Okay, so sodium fluoride present in the fluoride bulb is an inhibitor of, so here fluoride which is present in the this bulb is an inhibitor of the enolase of glycolysis. It prevents the continuous glycolysis and maintain the sugar level in that sample. This is needed. If we do not follow this procedure, the sugar level in the collected sample will decrease by 5 to 10 milligram per deciliter per hour. So you cannot get the true value of glucose if there is lag between the collection and the estimation. कलेक्शन एंड एस्टिमेशन, ये दोनों के बीच में का गैप अगर बहुत ज़्यादा हो गया तो हमको ट्रू वैल्यू ग्लूकोज की नहीं मिलेगी, क्योंकि कंटिन्यूस ग्लाइकोलिसिस की वजह से शुगर लेवल डाउन हो जाएगी. बिकॉज ऑफ इनिबिशन ऑफ दिस इनोलेज एंजाइम ऑफ ग्लाइकोलिसिस by the non-competitive inhibition, it inhibits the glycolysis and maintain the sugar level in the collected sample. So this is gray bulb, gray tube, gray cap tube. This is fluoride bulb. This is red cap tube. It is plain bulb. This is plain bulb. This is used for the serum estimations, various serum estimation. Various serum estimation. This is EDTA tube. EDTA tube, purple color EDTA tube. It is for the complete blood. This is for the complete blood count. This is CBC analysis, pathological investigation. EDTA tube is used. Apart from this question, there is again important question, that is order of draw. Order of draw मतलब सैंपल निकालने के बाद कौन से ट्यूब में सबसे पहले डालने का. एक्चुअली डिपेंड्स ऑन द इन्वेस्टिगेशंस विच आर ऑर्डर्ड, बट सभी का सभी अगर ऑर्डर किया है, सो देर इज वन सीक्वेंस विच शुड बी फॉलो, एंड देर इज वन न्यूमोनिक फॉर दिस. bunny rabbit, bunny rabbit, get pregnant food. Bunny rabbit get pregnant food. So this is sequence. Now see, this is blood culture tube, blue citrate for the coagulation profile, blue citrate for the coagulation profile, coagulation profile. This is blood culture bottle. The first is the blood culture bottle. First is the blood culture, followed by the blue, that is citrate, light blue citrate tube for the coagulation profile. Then red for the serum biochemistry analysis, serum. Also here yellow with clot activator, yellow or golden color is also there, yellow with clot activators for the serum analysis. For the serum analysis, EDTA, it is heparin tube, green, heparin, green heparin, particularly ABG analysis and various serum parameters, various biochemical parameter, this tube is used. Green tube, heparin bulb, and it is for the ABG analysis, mainly ABG analysis, arterial blood gas analysis. Then purple, this is purple. This is EDTA tube. It is for complete blood count. Also, it is for HbA1c estimation. HbA1c estimation. And this is last. This is gray tube. Gray tube, it is fluoride bulb. Sodium fluoride, potassium oxalate in the ratio of 1 is to sodium fluoride, it is 1, and potassium oxalate 3, 1 is to 3 ratio, which is there in the gray bulb. So this is gray tube, fluoride bulb for plasma glucose. Plasma glucose estimation. So this is practical aspect of this collection tube. So remember this sequence. Remember this sequence. Blood culture bottle first, second citrate for the coagulation profile, third is the red, fourth is the yellow with clot activator, same red and yellow, same. This is red tube, this is yellow tube with the clot activator. Fifth one is the heparin bulb, that is green cap. Then sixth one is the purple EDTA tube, and seventh one is the gray tube, fluoride bulb. So this is order of draw while collecting the blood sample. Remember this mnemonic: bunny rabbit get pregnant food. Bunny rabbit get pregnant food. Remember this mnemonic. This is very, very important. Now see, a mother came to OPD with 14-year-old mentally retarded boy complaining of joint pain, irresistible urge to bite his fingers and lips. This is the characteristic symptoms. The serum uric acid level was found to be elevated. So increase uric acid level. Mention the defective pathway related to the above mentioned condition. यहाँ पे pathway पूछा है, not the disease. So here, what is answer here? What is the disease is known as? Yes, correct. It is purine salvage pathway. Purine salvage pathway. Lesch-Nyhan syndrome. Hi Vivek. Hi Manoranjan. Lesch-Nyhan, your drug of choice. Lesch-Nyhan, correct. Lesch-Nyhan syndrome. Lesch-Nyhan syndrome, X-linked disorder. It is mostly affect the males. X-linked disorder mostly affect the males. There is complete deficiency of enzyme HGPRTase, hypoxanthine guanine phosphoribosyl transferase enzyme. This enzyme belongs to purine salvage pathway, which is particularly important in brain, RBCs. Brain and RBCs, where de novo synthesis of purine nucleotide does not occur. So it depends on purine salvage pathway, direct synthesis of purine nucleotides from the nitrogen bases. So when this enzyme is defective, it causes Lesch-Nyhan syndrome. There is irresistible, थोड़े बहुत नाखून हम लोग भी खाते हैं. ओके, रोहित शर्मा कितना नाखून खाता है मैच में देखा होगा आपने. दिस इज नॉर्मल इन स्ट्रेस, बट इतना नहीं कि खून निकले, इतना भी नहीं. सो इरिजिस्टेबल अर्ज टू बाइट देयर फिंगर, लिप्स, सेल्फ म्यूटिलेटिंग एक्टिविटी इज देयर, मेंटल रिटार्डेशन इज देयर बिकॉज ऑफ डिक्रीज न्यूक्लियोटाइड सिंथेसिस इन द ब्रेन. Because of decreased nucleotide synthesis in the brain, and joint pain because of increased uric acid level, which causes the gout-like symptoms. Because of increased level of PRPP. So we'll see this. See, this is the pathway which is defective. So this is defect here. So hypoxanthine guanine phosphoribosyl transferase. This is purine salvage pathway in which hypoxanthine is converted into inosine monophosphate and guanine is converted into guanosine monophosphate. So when there is defect in hypoxanthine guanine phosphoribosyl transferase enzyme, there is accumulation of PRPP, which is the substrate for de novo purine nucleotide synthesis, and it increases the uric acid level. Also this hypoxanthine and guanine, it is converted into uric acid. So it increases the uric acid level and causes the gout-like symptoms. So this is Lesch-Nyhan syndrome, X-linked disorder, particularly affect the males. Irresistible urge to bite their finger and lips, self-mutilating behavior, head banging will be there. self-mutilating activities, their mental retardation will be there because of decreased nucleotide synthesis in the brain, because brain and RBCs, they are dependent, completely dependent on the purine salvage pathway for the nucleotide synthesis. So there is mental retardation, head banging activity, self-mutilating activity, increased uric acid level in the Lesch-Nyhan syndrome. Symptomatic treatment is given. Allopurinol can be effective to decrease the uric acid level. Okay. The next one, a 13-year-old boy was brought to the clinic with jaundice, fatigue, muscle stiffness, tremors, and behavioral changes. Examination revealed an enlarged liver, spleen, and Kaiser ring was noted. Kaiser ring was noted. What is probable diagnosis? So there is image यहाँ पे missing है. See, so around the cornea, around the decimate membrane of the cornea, there is golden brown ring. Suppose there is golden brown ring around the decimate membrane of the cornea in the here answer is, so these 1 2 3, these are the very important questions. This is also related with the calcium, so these are very important questions. So here answer is Wilson's disease. Wilson's disease, hepatolenticular degeneration. What is hepatolenticular degeneration? There is involvement of liver, lenticular nucleus of the brain is involved. Lenticular nucleus of the brain is involved. There is a golden brown ring that is known as Kaiser-Fleischer ring, that is KF ring around the cornea. Also there is sunflower cataract in the Wilson's disease due to deposition of the copper. So Wilson's disease and Menkes disease, these are related with the copper metabolism. So these behavioral changes, tremors, jaundice, fatigue, muscle stiffness, these are the features of copper excess in the Wilson's disease because of mutation in ATP binding cassette transporter 7B, and this is Menkes disease. It is due to mutation in ATP 7B, and this is ATP 7A. Menkes disease. M come first, A come first. M first, A first. Remember like this. So ATP7A mutation causes the Menkes syndrome, where still wiry hair is there. This is neurodegenerative disorder. Still wiry hair and hypopigmented patches along with the mental retardation is there in the Menkes syndrome. Also there is aortic aneurysm can be there in the Menkes syndrome. In Wilson's disease, there is neurodegenerative, this is behavioral changes, tremors, there is involvement of liver, there is involvement of lenticular nucleus of the brain, there is involvement of decimate membrane of the cornea, KF ring, there is involvement of the lens, that is sunflower cataract in the Wilson's disease. This is copper excess, this is copper deficiency. Copper excess, copper deficiency. ATP7B mutation in Wilson's disease, ATP7A mutation in the Menkes disease. Tetany, it is when serum calcium level goes below 7, it causes carpopedal spasm, and typical this position of the hand will be there in the tetany. Acrodermatitis enteropathica, this is zinc deficient condition. Diarrhea, alopecia, dermatitis, delayed wound healing. Also sexual problem will be there because of zinc deficiency. These are the, so Wilson's and Menkes will discuss. See, Menkes disease, it is due to mutation in ATP7A. So there is improper absorption of copper from the intestine. So copper deficiency is there in Menkes disease. Copper deficiency. Copper deficiency is there. While in the Wilson's disease, this is Wilson's disease. In Wilson's disease, there is copper excess. Why copper excess? Because there is mutation in ATP7B, and ATP7B का role क्या है? ATP7B is important for incorporation of the copper into ceruloplasmin and copper excretion in the bile. So it affect the excretion of the copper. So there is copper excess which accumulates in the liver, causes the jaundice, which accumulates in the brain, which causes the mental problem. So there is decreased ceruloplasmin level in the Wilson's disease. So this is very, very important. Wilson's disease, Menkes disease. Wilson disease, Menkes disease. Okay. So copper, it is required for the lysyl oxidase enzyme, which is important. Lysyl oxidase has important role in the collagen cross-linking. Lysyl oxidase, it is important in the collagen cross-linking. Strengthening of the collagen, it is very, very important. Lysyl oxidase. Now the next question. See this image. See this image. This is the lens. This is ectopia lentis. This condition is known as ectopia lentis. So this is feature, ectopia lentis is the feature in two disorders. कौन से दोन disorders? One is the homocystinuria, another one is the Marfan syndrome. Homocystinuria and another one is the Marfan syndrome. What is Marfan syndrome? Marfan syndrome, there is a tall stature, skeletal involvement is there, Marfan syndrome. There is involvement of bone in the Marfan syndrome. There is involvement of eye in the Marfan syndrome. And there is the subluxation of lens is there in the Marfan syndrome, and homocystinuria, there is also subluxation of lens. So here inferomedial subluxation of lens, it is seen in homocystinuria, while the superotemporal subluxation of lens, it's seen in the Marfan syndrome. See here, a 3-year-old, this is not, this is wrong. So 3-year-old child was brought to the hospital with chief complaints of failure to thrive and developmental delay. Failure to thrive means difficulty in weight gain. The child was tall, thin, elongated limbs and digits. Eye examination revealed subluxation of ocular lens, means ectopia lentis is given. Urine showed elevated levels of methionine and homocysteine. So there is elevated level of methionine and homocysteine. The cyanide nitroprusside test was positive on urine sample. Which of the following amino acid need to be supplemented in the diet in above disorder? So methionine, homocysteine. Urine showed elevated level of methionine and homocysteine. So this is very, very important condition. Here answer is, what is the answer here? What should be answer here? Yes, in homocysteine, nasal means inferomedial, and Marfan superotemporal. Correct? 54 divine. Hi carpal tunnel. Hi Ajit Raj. Cysteine is the correct answer. Cysteine is the correct answer. See here, this diagram, this pathway is very important. Now see here, in the methionine metabolism, we'll discuss in short this methionine metabolism. In the methionine metabolism, this methionine, see, methionine is converted into, अरे भाई रुक जा. So this methionine is converted into SAM, that is adenosine adenosyl methionine. SAM is the universal methyl group donor. Remember, this is important for the transmethylation reaction. Now this SAM is converted into S-adenosyl homocysteine. Here it is methyl group is donated, which is accepted by an acceptor. For example, norepinephrine here is converted into epinephrine. Norepinephrine is converted into epinephrine, or guanidinoacetate acetate is converted into creatine. It is converted into creatine. So this is transmethylation reaction. Now S-adenosyl homocysteine, it is by the adenosyl homocysteinase, it is converted into homocysteine. It is converted into homocysteine. And homocysteine is converted into methionine. And this reaction is important because this required vitamin B12, and in this reaction methyl tetrahydrofolate is converted into tetrahydrofolate. folate. So vitamin B12 and folic acid dependent reaction, homocysteine to methionine. So this is methionine metabolism. Now this homocysteine, it is converted into, homocysteine is converted into cystathionine, and this is converted into cysteine plus homoserine. There is serine here. Okay, now this is pathway. This is methionine metabolism, metabolism of sulfur containing amino acid. Now this is a case of homocystinuria where defective enzyme is cystathionine beta synthase. Beta synthase. This enzyme is defective. Cystathionine beta synthase pyridoxal phosphate dependent enzyme. If this is defective, this phase is defective, there is elevated homocysteine level, there is elevated methionine level. And elevated homocysteine level will give the cyanide nitroprusside test positive. Now, which amino acid synthesis will decrease here from this diagram? See, there is increased methionine, there is increased homocysteine level, which is decreased, cysteine level will be decreased. So, in the treatment, cysteine is given. Cysteine now becomes essential amino acid in this patient. So, cysteine supplementation is given. Got it? So, this is homocystinuria. Homocystinuria. Inferonasal subluxation, inferomedial or inferonasal subluxation of the lens. Elevated homocysteine level gives the cyanide nitroprusside test positive. There is tall, thin stature with elongated limbs and digits, and there is elevated methionine and homocysteine level. So cysteine has to be supplemented in the diet. Marfan syndrome, there is mutation in fibrillin 1 gene. There is mutation in fibrillin 1 gene in Marfan syndrome. Superotemporal subluxation of the lens because of involvement of zonular fibers of the lens. Okay, so this is homocystinuria. The following image depict a particular process involved in the expression of genes. A is a type of ribosome which plays a role in this process. Which of the following is representative of? So here A, this is A. So what is this? What is this process is known as? See, exon intron, and this is lariat formation, loop formation, and this intron loop is removed by this A. So this is, what is this process is known as? I am not asking you the answer. What is this process is known as? What is this intron exon? ये क्या है? What is intron exon? ये तो mRNA. See, there is no doubt in that this is mRNA. So this process, what is this process is known as post-transcriptional modification. In the post-transcriptional, yes, correct. This is splicing. This process is known as splicing. Removal of the intron and joining of the exon together. There are two types of splicing. One is the intron mediated, that is also known as self mediated splicing, and second one is the spliceosome mediated splicing. So in the spliceosome mediated splicing, snRNA, small nuclear RNAs, which is uracil rich RNAs near about 20 to 24 nucleotide in length, snRNA, small nuclear RNA, plus near about 60 proteins they take part. 60 proteins, and together this ribonucleoprotein. So together this is known as SNRP, small nuclear ribonucleoproteins. SNRP. This is pronounced as SNRP, small nuclear RNA plus ribonucleoprotein. These are important. Means U1, U2, U4, U5, U6. These are the snRNAs which are involved in the splicing process, removal of the intron, means intervening sequences, non-coding sequences, and joining of the coding sequences together. This structure is known as lariat formation or the loop formation. Here answer is snRNA. This is post-transcriptional modification of mRNA is going on here. Post-transcriptional modification of mRNA. Regarding siRNA, that is small interfering RNA or the silencing RNA, and miRNA, these are responsible for the inhibition of gene expression, means decrease gene expression. They generally causes the silencing of mRNA or they causes the degradation of mRNA. Just remember these two things regarding these two. snRNA, small nuclear RNA, they are required for the silencing. They are required for the post transcriptional splicing of the mRNA. Now see, just remember which technique is used for the which molecule. So for DNA, RNA and protein. For the DNA, the Southern blotting, Edward Southern, it is given by the Edward Southern. So it is Southern blotting for the DNA. These are the laboratory jargons. Means this is Southern, that's why it is Northern, this is Western, and also there is Eastern also, which detect the post translational modifications in the protein. Okay, Eastern is also there. That is about the post translational modification in the protein. Southern blotting technique detects the DNA, northern blotting technique detects the RNA, and western blotting is for the detection of the protein. It is for the detection of the protein, and eastern blotting, it is for the post translational modification in the protein. So these are the blotting techniques. Now see, coenzyme required for the PDH complexes, or there may be a question, what do you mean by E1, E2 and E3 of pyruvate dehydrogenase complex? So this is diagram. E1, E2 and E3 of pyruvate dehydrogenase complex. So E1 is pyruvate dehydrogenase itself, E2 is the dihydrolipoyl transacetylase, and E3 is dihydrolipoyl dehydrogenase. See, E1 pyruvate dehydrogenase, E2 dihydrolipoyl transacetylase, and E3 is dihydrolipoyl dehydrogenase. Here, what are the 5 coenzymes required for this pyruvate dehydrogenase complex, or alpha ketoglutarate dehydrogenase complex, or branch chain ketoacid dehydrogenase complex? So here thymine pyrophosphate is required. Then here lipomide is required. Then coenzyme A is required. This coenzyme A. Then FAD and NAD. So here see, B1 is required. Then B2 is required. B3 is required. Then B5 is required, and the lipomide. These are the coenzymes required for this pyruvate dehydrogenase complex, also for the alpha ketoglutarate dehydrogenase complex, also for branch chain ketoacid dehydrogenase complex. Thymine pyrophosphate, apart from these 3, it is also required for the transketolase enzyme of the HMP shunt, and the thymine status of the body can be detected by detecting the RBC transketolase activity. It can be detected by RBC, detecting the RBC transketolase activity, thymine status of the body. This is linked reaction, pyruvate dehydrogenase reaction. It is very, very important. 5 coenzymes are required. Okay, 5 coenzymes are required. 3 enzymes: PDH, dihydrolipoyl transacetylase, and dihydrolipoyl dehydrogenase. Now see, this is again important question. Very easy question, but important question. A patient came to the hospital with complaint of abdominal pain. Routine investigations were unremarkable. On observation, the urine turned black. On standing. Which of the following enzyme is likely to be defective in this patient? So also there is the deposition of black pigment in the palmar creases, ear cartilage, also in the eyes. There is deposition of black pigment, that is known as alkaptone, and urine turned dark on standing, black color urine on standing. As such, the disease is asymptomatic, but on urine turns dark on standing on exposure to the air because of oxidation. So this is a case of Yes, homogentic oxidase is the correct answer. And what is the name of the disease? It is a case of alkaptonuria. Alkaptonuria because of deficiency of, yes, correct. Hi Ritvik. Hi Dr. Ajit. So it is correct. Homogentic oxidase is defective, which accumulates homogentic acid and it is diverted for the production of alkaptone. And alkaptone deposition in various tissues causes the arthritis. It gives the black pigmentation to the various cartilages and excretion of homogentic acid. It can be detected by the Benedict test. Also, homogentic this is converted into black color pigment on exposure to air, and urine turns dark on standing. So this is defective in the patient with alkaptonuria. Phenylalanine hydroxylase, it is defect in the that is phenylketonuria. Tyrosine is defective in the albinism. Fumarate acetoacetate hydrolase, it is defective in the tyrosinemia. It is tyrosinemia type 1. F is there first. Tyrosinemia type 1. Okay. Tyrosine transaminase, this is tyrosinemia type 2. Now, there are a lot of questions on the uncoupler, inhibitors of electron transport chain, oxidative phosphorylation, and uncouplers. So, remember this. So, see, when there is pumping of the proton occurs, so see, electron flow from complex 1 to coenzyme Q to the complex 3, then cytochrome C, and then complex 4. How the flow of electron occurs from complex 1 to coenzyme Q, from coenzyme Q to complex 3, there is no involvement of 2, complex 2, complex 3, then cytochrome C, then complex 4, then the ATP synthesis occurs. And from complex 2, it is start from the complex 2, then coenzyme Q, then complex 3, then cytochrome C, then complex 4, and then ATP synthesis occurs. So when there is continuous flow of electron through the complex of electron transport chain, there is pumping of proton occur, 4 from the complex 1, 4 from the complex 3, and 2 from the complex 4. There is no pumping of protons from the complex 2. Okay, because energy generated during the transfer of electron is very low, which is unable to pump the proton into the intermembrane space. Also, this is not a membrane spanning protein. These are the membrane spanning protein. This is not a membrane spanning protein. So there is continuous pumping of the protons into the intermembrane space that gives positive outside and negative inside towards the matrix side, that generates the proton gradient across the membrane, which is important for the ATP synthesis. This is chemiosmotic hypothesis. This is chemiosmotic hypothesis. Now what is role of uncouplers? Uncouplers increases the permeability of this membrane. Uncouplers increases the permeability of this membrane. As such, this membrane is impermeable. ये membrane impermeable है, यहाँ से कुछ भी नहीं जाएगा. लेकिन अनकपलर्स ये मेम्ब्रेन की परमेबिलिटी बढ़ाता है, उसके वजह से प्रोटॉन ग्रेडियंट डेवलप ही नहीं होता और एटीपी सिंथेसिस ही नहीं होता अनकपलर्स के प्रेजेंस में. ओके, नाउ सी दीज आर द इनहिबिटर्स. complex 1, complex 2, complex 3, complex 4. You may get question on this part specifically and this part. Rotenone is important here. So pyridine, amobarbitol, rotenone, this inhibits the complex 1 of electron transport chain. Malonate inhibits the succinate dehydrogenase. Carboxyn and this trienoyl trifluoroacetone, this TTFA, this inhibits the complex 2 of electron transport chain. British anti-lewisite, antimycin and fenformin, it inhibits the complex 3 of electron transport chain. And these gases, cyanide, carbon monoxide, hydrogen sulfide and azide, it inhibits the complex 4 of electron transport chain. So this topic is important here. So these are this chart is from the Lesch-Nyhan's biochemistry and it is important. Now see the ATP ADP transport of ATP and ADP across the mitochondria. It is attractylocyte which inhibit this. Then FO subunit, O for oligomycin, its inhibition by the oligomycin. So FO unit of ATP synthase, it is inhibited by oligomycin and venturicidin. F1, it is inhibited by the orovertin. These are the uncouplers which disrupt the barrier in the membrane, which increases the permeability of the membrane. So chemical uncouplers, 2,4-dinitrophenol, dinitrocresol. This is phenylhydrazone. This is aspirin in high doses. And physiological uncouplers: thermogenin, thyroxine, long chain free fatty acid, and unconjugated bilirubin. That's why in Kernicterus, when there is increase in the unconjugated bilirubin, it is toxic. So thermogenin, thyroxine, long chain free fatty acids, and unconjugated bilirubin, these are the physiological uncouplers. These are chemical uncouplers. This potassium ionophores, generally ionophores increases the movement of other ions. Potassium ionophores means increases the movement of potassium ions. So it disrupts the barrier across the membrane. So proton gradient does not develop. So these are valinomycin, gramicidin, and nigricin. These are the ionophores, particularly potassium ionophores. Valinomycin, gramicidin, and nigricin. This chart is very, very important for any entrance examination. Oxygen dissociation curve. Oxygen dissociation curve. Hemoglobin dissociation curve. It is sigmoidal in shape because of binding of O2 to hemoglobin is cooperative. Cooperative means when one oxygen molecule binds to the hemoglobin, the subsequent O2 binds with high affinity to the hemoglobin molecule. This is known as cooperative binding. मतलब एक बंदा आगे गया तो वो बाकी सारे बंदे को आगे खींचेगा, वैसे पीछे नहीं खींचेगा, आगे खींचेगा, अपने तरफ खींचेगा. So that is cooperative binding. So oxygen dissociation curve, it is sigmoidal in shape because of cooperative binding. This is oxygen dissociation curve. And it shifts to the right. It shifts to the right when there is decrease in the pH, increase in the partial pressure of CO2, increase in the 2,3 bpg concentration, and increase in the temperature level. So shift of oxygen dissociation curve to the right. When pH decrease, partial pressure of CO2 increases, 2,3 bisphosphoglycerate increases, and increase in the temperature. It causes the unloading of oxygen from the hemoglobin to the tissues. It causes the supply of oxygen to the tissues. Decrease pH, increase partial pressure of CO2, increase 2,3 bpg level, and increase temperature level. So remember this oxygen dissociation curve, cooperative binding, sigmoidal shape, and when it shifts to the right. So 2,3 bpg is important for shifting the curve to the right in case of anemia, in case of high altitude, in case of chronic obstructive pulmonary diseases. It is important. Oxygen dissociation curve. See the diagnosis. What is the diagnosis here? So it is curve. It is bow legs. Bow legs. So bow legs, it is important. It is rickets, weight bearing joints, rickets because of spongy bones. The bone becomes spongy and pliable bones. So it curve. It get curved. Bow legs. It is symptoms of rickets. Vitamin D deficiency. And see this megaloblastic anemia with increased excretion of farm-immunoglutamic acid, FIGLU, in histidine load test is seen in. So there is megaloblastic anemia in B12 deficiency. There is megaloblastic anemia in the folic acid deficiency. Now how to differentiate between these two? See, megaloblastic anemia means large oval RBCs and hypersegmented neutrophil. This is feature of megaloblastic anemia. There is increased MCV. So how to differentiate whether it is B12 deficiency or folate deficiency? See, when folate in histidine load test, when histidine is given, this is converted into farm-immunoglutamic acid. Farm-immunoglutamic acid, and this is converted into glutamate. This is converted into glutamate. So in this reaction, the tetrahydrofolate means folic acid is converted into farm-immuno tetrahydrofolate. Okay, tetrahydrofolate. Now when there is THF deficiency, when there is folic acid deficiency, when this reaction is blocked, this FIGLU, it is excreted in the urine. So FIGLU excretion in urine indicates the folic acid deficiency. While when there is B12 deficiency, there is excretion of methylmalonic acid in the urine. In the B12 deficiency, there is methylmalonic acidemia, methylmalonic aciduria, and this methylmalonic acid that decreases the myelin synthesis, that causes the degeneration of spinal cord. So that's why subacute combined degeneration of spinal cord in the B12 deficiency. Here folic acid deficiency, there is excretion of FIGLU in the urine. folic acid deficiency that hampers the purine and pyrimidine nucleotide synthesis, that hampers the DNA synthesis. So DNA synthesis means nucleus becomes smaller and the larger cytoplasm that gives the large oval RBCs. So megaloblasts formation is there in the B12 and folic acid deficiency. So this is folic acid deficiency. B12 deficiency also causes megaloblastic anemia, methylmalonic aciduria, and subacute combined degeneration of spinal cord. Riboflavin deficiency, circumoral manifestations, circumcorneal manifestations are there in the riboflavin deficiency. Niacin deficiency, diarrhea, dementia, dermatitis. Classical 3Ds, Castle's necklace, glove and stocking appearance of hand and feet in niacin deficiency. So remember these sources of nitrogen and the specifically remember this C4, C5 and N7 of the purine ring, it is given by the glycine, and N3, N9 it is given by the glutamine. It is given by the glutamine purine ring. So this is important. Glycine is a source of C4, C5 and N7 of the purine ring. Glutamine is N3 and N9. Okay. And in case of pyrimidine, the aspartate maximum it is given by the aspartate, it is N1, C4, C5, C6, it is given by the aspartate. Okay, now see, this is ring, this is pyrimidine ring. So entire portion this side, so 1 2 3 4 5 6, this portion is given by the aspartate, this is given by the aspartate. So N3 it is from the glutamine and C2 it is from the CO2 in case of pyrimidine ring. In case of pyrimidine ring, purine ring, in case of purine ring it is like this, it is like this. So see, C4, C5 and 7 it is contributed by the glycine, N3, N9 it is from the glutamine, then N1 from the aspartate, this is C6 from the this is from the CO2, and this C2 from the formyl tetrahydrofolate and C8 from the methanyl tetrahydrofolate. So this is given by the C2 and C8, it is given by the tetrahydrofolate means folic acid, C2 and C8 of the purine, and the conversion of uridylate into thymidylate, the folic acid is required. So folic acid is required for purine and pyrimidine synthesis, hence it is important in the DNA synthesis, folic acid. Vitamin B12 and folic acid, they are connected for, in the methionine synthase reaction. So they are interconnected. So when one is deficient, when B12 is deficient, there is folate deficiency, that is in the folate trap. That is in the folate trap. See, this reaction, homocysteine to methionine conversion, this is methionine synthase enzyme. Methionine synthase enzyme. It is B12 dependent reaction, and in this reaction, methyl tetrahydrofolate is converted into tetrahydrofolate. If there is block in this reaction, this is known as folate trap. Folate trap means B12 deficiency causes folate deficiency. There is functional deficiency of folate. This methyl tetrahydrofolate is of no use. So that's why in B12 deficiency also there is folate deficiency. So deficiency of both vitamins, this vitamins B12 and folic acid causes the megaloblastic anemia. And this folic acid, it is required for synthesis of C2 of the purine, C8 of the purine, also required for the thymidylate synthesis. Thymidylate synthesis. That's why it is important. B12 and folic acid. So this covers the maximum image based question which are related with the FMGE examination. Also do the important tables, for example glycogen storage disorders, then the mucopolysaccharidosis, sphingolipidosis, then DNA repair mechanism. These are the important tables, lipoproteins, collagen types, various types of the collagen. These are the important types which are related with the entrance examination, which are frequently asked in the entrance examination. The PDF of this lecture will be uploaded on the PW Medit Telegram channel. This is a link for the PW Medit Telegram channel. So this is all about the today's lecture. So keep watching. Best of luck, all of you. Thank you very much. Hi, Dr. Mano. So thank you all of you. Thank you Carpal Tunnel. Thank you Ritvik. Thank you Drug of Choice. Thank you Jonas. Hi Dr. Ajit. Hi Soumya. Hi Ankit. Hi Manoj. Hi 54 Divine. Hi Apurva. Hi Sub Zero. So thank you all of you. Thank you very much.